sure additional people will join us. We have plenty of people who've been notified and who are registered. So we are the Toqq-Rcc Echo Series. We're glad you're here today. My name's Katie Knight, and I am the project manager for Toqq-Rcc, working with Dr. Wolf Birchfield. And today we've got Grace Martin as our guest speaker. I'll let Libby tell you a little bit more about her. But we want to get through a few housekeeping slides first before we get started as people are joining our Echo. We always start and end on time. That's our goal. So I will hopefully help make sure that happens. We do have a case presentation embedded within our didactic, so we will learn all sorts of fun things today. Just a reminder, please sign in for attendance for continuing education credits, and so that we can also network a little bit. These are our conflict of interest disclosures for your review. And just a reminder, these slides do get added to the Midwest Cancer Alliance, I'm sorry, the Masonic Cancer Alliance website for enduring materials. So you can review back to them. And at any time you can reach out to me. I'll be sure my email's in the chat box if you have any questions about any of these slides. So just a reminder, you've got to sign into Zoom, first and last name. And if it's possible for you to put your name in your Zoom box by adding it here, that would be very helpful too. Continuing education credits, we offer those as part of your participation here. And there are certificates of attendance available if you're not interested in getting the CEU. The activity code today for our program is 12 puns. I attempted to come up with a punny response to that, but that was the best I could do. So I won't ever do that again, I promise. Anyway, it's 12 puns, and the deadline is Thursday, July 22nd by 5 p.m. Remember, that is a firm deadline. You can enter that code into the phone number listed or eads.com, and there's, of course, an app for that. This project is funded by a Pfizer Independent Grant for Learning and Change, and of course support from the University of Kansas Cancer Center, and the Masonic Cancer Alliance. We are recording this Echo for QI purposes, but also as offering of enduring materials that people can refer back to. By participating in this, you are consenting to be recorded. A few Echo tips for you. Make sure you're muted if you're not speaking. Speak clearly when you do speak up, and if you can turn your camera on, we would appreciate that. We'd love to see everybody's faces and engagement during our sessions. We do like to do polling questions. When those happen, they'll pop up, you'll give us your answer, and we'll get to see the results in real time. All right. When we have case presentations, it's important to know that we are not using any real patient information, and we are absolutely committed to protecting patient privacy. All right, I'm wondering, let's see, we need to do a little check-in, and I think maybe I've forgotten the check-in slide. So let's go ahead and stop sharing here and check in to see with who is already joined our Echo session. So it looks like we have Stacy on the call, Carla, and Annie. Trish, Tracy, Libby, Grace, and Jen are also on the call. Is there anybody that's on that has not attended before? Let's see, I don't think so. Stacy, I feel like you've attended before. Well, we're also glad that you're here. It looks like Jennifer's connecting to audio. We're glad you're here. We know more will be joining, but we're gonna go ahead and get started because we've got plenty to discuss today. So, Libby, would you like to introduce yourself and our guest speaker?
Yes, of course. I'm Libby Wolf Birchfield. I am a medical oncology and palliative care physician, and my clinical specialty in oncology is a focus on genitourinary cancers, including kidney cancer. I am pleased to introduce my colleague, Dr. Grace Martin, who has a doctorate of pharmacy as well as being a board-certified oncology pharmacist. And she is one of the clinical oncology pharmacists at the University of Kansas, as well as one of our cancer care education pharmacists. And I'm so pleased and so lucky to be able to work alongside her. And we're so pleased to have her join us for this part of the series so that we can all learn from her expertise and learn about some of the policies and protocols that KU has in place. So thanks for being here, Grace.
Thank you for having me.
Well, so we often do, in addition to some of our other check-in slides and everything at the beginning, we do have a learning objective. So for this particular session, the learning objective is to expand knowledge about the breadth of tyrosine kinase inhibitor or TKI toxicities, as well as monitoring and management. They present to medical oncology in order to figure out a plan of care. The oncologist does an IMDC risk stratification and sees that they're intermediate risk, and that's because they presented with de novo metastatic disease. And they engage in some medical decision making as a team, and based on MixW's history of this multiple sclerosis that is on active treatment, it was felt that doing immunotherapy is just too dangerous, and it wasn't something that would be medically appropriate. And so therefore and also given that MixW presented with bone metastases, the decision was made to proceed with treating with cabozantinib. And so I think when thinking through this sort of process, the next questions are often, well, okay, so how exactly does this work, and what does that mean for the experience of this patient, especially someone who's been so clear about wanting to live a good quality of life and wanting to pursue longevity, but also a really good quality of life. For this next study, or for this next set of slides, thankfully Grace is here with us, and as a pharmacist and a board-certified oncology pharmacist, she's in such a good position to be able to talk to us about some of the mechanism of action here. So I'll let her hand over the reins, and I'll pick it back up with the case study.
Great, thank you. So tyrosine kinase inhibitors are a class of oral anti-cancer therapy that underwent extensive development and clinical testing in the late 1990s and the early 2000s. They're approved for multiple malignancies in the setting of advanced disease. And while this particular class of agents is the focus of this session, a lot of the principles we're going to talk about today revolving oral treatments are going to apply to your patients on other kinds of therapy, like those on BCR-ABL TKIs for CML, BRAF or MEK inhibitors for BRAF metastatic melanoma, lung cancer, or colorectal cancer. But we'll start off by talking about TKIs. So tyrosine kinase inhibitors, or TKIs, are multi-kinase inhibitors that block the activity of several protein kinases associated with angiogenesis, including these VEGF receptors you see in the middle. Angiogenesis plays a crucial role in the growth of solid tumors, so blocking VEGF receptors presents an opportunity for targeted therapy. When I'm talking to a patient about how angiogenesis inhibitors work, I start by explaining that as the tumor grows, it sends out signals to generate the formation of new blood vessels so it can continue to receive the oxygen and the nutrients that it needs to survive. The purpose of these angiogenesis inhibitors is to block the formation of those new blood vessels to keep the tumor from growing and spreading. So some tumor types, like renal cell carcinoma, are especially sensitive to angiogenesis inhibitors, so they can be used as single agents. But we're starting to see more and more combination therapy with agents like immunotherapy and cytotoxic chemotherapy when they don't have overlapping toxicities. Because these agents work intracellularly, it's thought they can overcome resistance mechanisms to other VEGF inhibitors, like I think about bevacizumab, where it works extracellularly. So these TKIs also block kinases involving the tumor microenvironment, like fibroblast growth factor receptor and platelet-derived growth factor receptor beta. Blocking these multiple pathways results in inhibition of tumor growth. So here are the disease states with FDA approvals for oral agents with angiogenesis effects. Of note, sunitinib is approved for adjuvant therapy in stage 2 to 3 renal cell carcinoma, but it's still considered controversial due to the lack of overall survival benefit. And this table also includes the most recently approved TKI for renal cell carcinoma, tivozanib, that was just approved in March of this year. And here are the targets of these multi-kinase inhibitors. Notice that VEGF is a target for all of these TKIs. That means they have a risk of adverse effects commonly seen with VEGF inhibitors like bevacizumab, including hypertension, wound healing effects, and proteinuria. However, because they have additional targets, we also have to monitor for additional side effects. As a pharmacist, when I'm looking at side effects of a medication, I'm always thinking about that mechanism. So I'm really interested in these targets and what side effects they may cause for patients.
Thank you so much. That's really thorough. And as you see on that former slide, actually, Katie, if we can just go back there for a moment, I'll just point out that, we think of, a lot of times we get focused on the VEGF component of a lot of these agents because it's so prominent and it's really, really important to their mechanism of action. But as you can see, these agents that are in common use today, they're kind of messy. I mean, they have a lot of these other targets that they hit. For example, FLT3, which makes us think about AML with sorafenib, looking at other, if we look at things, for example, with lenvatinib, how it hits KIT, there's a really wide breadth here. And that's why, when we are communicating with patients about things, we certainly talk about the so-called on-target effects of these VEGF therapies. However, we can't just limit our conversation only to those, because it's clear that these are, some of the way that these help patients is by being broader than just one single mechanism of action. And especially when you compare to some even more VEGF specific therapies, because since these are approved for multiple diseases, some of these diseases also have the option of being managed with something like bevacizumab, for example. But some of the special sauce of these drugs, I think of as being really in part due to how messy they are and how they hit a bunch of receptors. And so I think we want to still be broad in our counseling and trying to prepare patients for the on-target effects, but also talking to them about how that the on-target effects can be a wide breadth of that. And it's tough. I mean, I think, because when we're counseling patients who have renal cell carcinoma, a lot of their experience in terms of medicine management is going to be limited to these sort of drugs and or immunotherapy. But with other conditions, if depending on what patients are going through, they may have seen cytotoxic chemotherapy before. And it's just such a different experience. And so I think I just want to draw your attention to the sort of beauty that is the messiness of these medicines, because this is kind of how we help them, but it just means that we have to be pretty broad, not get too specific in our counseling, because we want to prepare patients for the whole experience. But we can get back to the case. So in meeting with your patient, so mixed-W ends up getting started on cabozantinib, and the goal is to start it the way that it is dosed based on clinical trials like the METEOR trial and others. And in those trials, it started at the max dose of 60 milligrams per day. And so when doing that and talking to this patient about this different side effects, as I said, because of how kind of messy these medicines can be and how many potential receptors they can hit, it's important to have a really thoughtful discussion on how to prepare patients to look out for side effects, to manage them, and how to communicate them. So this next few slides is going to look some into that. So when we think about the adverse effects of these treatments, there really is a pretty wide breadth, as I said. And some of what and because these agents are getting approved for more and more indications, for example, I also treat prostate cancer, and cabozantinib specifically is being investigated along with an immunotherapy medicine for prostate cancer, as well as other targeted mutations for other cancers. It's so important to really look at all these different multi-system effects. So to start out with, when we're talking to patients, and we can start out by talking about hepatotoxicity, for example. So when we think about this, it can be a little bit tricky to talk to folks about this, because we all know how important our liver is to our whole body's functioning, and how to keep everything, and how it helps keep everything in balance. But it is important when I'm talking to patients, I do specifically mention that there is a risk of hepatotoxicity, although generally speaking and sort of statistically, there's a very low chance that they would have permanent liver damage or would have any very severe reaction. But it's something that we have to look out for. And so while there is I don't know about some of you, but sometimes when I'm meeting with folks about oral cancer therapies, there are these moments where patients will say, well, I mean, I'm just taking a pill. Do I have to come in? I mean, I can just take the pill at home. And I don't know, Grace, if you, in your counseling visits with patients in clinic, if you have encountered that too, but it's not uncommon for patients to say, well, look, doc, it's not like I don't want to see you, but I don't have to go up to the infusion room for this one. So can I just stay home? And I bring them back to the hepatotoxicity risk in some of those discussions. Again, not to be manipulative or scary, but to say we have to be vigilant and to actively look for these potential effects. And this is one of the ones that we need to be able to have those labs and then debrief about the labs. So you shouldn't, clinicians should not feel bad about talking to patients about that. And telling them that, yes, in fact, they do need to come in, because even though it is just uphill, it still needs the same amount of oversight, and in some ways almost more than with some IV therapies, because patients are fully responsible for them, which is really tricky. So we can look next at hand-foot skin reaction, and I have some a little bit more in-depth slides about this, so we'll come back to it. This is one of the things that I think a lot of us who've prescribed some of these agents or have seen these agents or have taken them, what we often think of sort of this hand-foot syndrome. So this can be a really tricky toxicity because it's common to these VEGF tyrosine kinase inhibitors, very, very common. And the severity and frequency of this varies for different agents, but is a really common toxicity. And so I'm going to delve into that a little bit more, because I know that Grace also feels very, very passionately about this, because in our clinical collaborations, she and I are often of the same, we're very aligned in our thinking about how important it is to really prepare patients for this and give them a good protocol to start. But so we can look at some of the others here. Thyroid disorders. This is another one that I do mention to patients when we're talking about, well, why do you have to come in here and get stuck for a blood draw? Well, because hypothyroidism is extremely common. Thyroiditis and hyperthyroidism also can occur, but hypothyroidism is particularly common. And so we need to be able to monitor for this, because patients can feel very ill if they have hypothyroidism that's not managed. Some of them need TSH drawn really frequently, and this is very particularly specific in folks who have a history of thyroid cancer. And so it's important to always refer back to the packaging instructions. There isn't a one-size-fits-all approach for the entire class of medicines. I would encourage you to kind of look back at the monitoring protocols for each of them when delving into these discussions. And looking at heart disease. So this is another one that can be a little bit spooky. And this one, while I would say that most of us are not going to be doing specific blood tests to monitor for this, for example, unless in conjunction with a cardio oncologist, or unless we have a patient with a history of heart failure, in which case we might do something like order a BNP. However, this is done clinically. This is one reason why we have to see folks. Now, monitoring with echocardiograms is recommended, and the frequency does vary. But again, this is another reason why we do have to see people. We want to make sure that we're talking to them. Are they having orthopnea? Are they having swelling? What's going on? How is their breathing when they walk? This is another thing that we really monitor for clinically. Hypertension. This is one that can be really tricky. So because it's so common, and when I counsel patients about this, I really tell them that this is one of the few guaranteed symptoms. And that's because while it may not require pharmacologic management, meaning that we may not have to start them on a blood pressure medicine, or they may not have to go up on their doses or add, change things around, it is something that happens almost, it's not truly universal, but almost universally, some degree of hypertension. And so while there are different agents have different frequencies of monitoring, so again, I would refer back to that. Sometimes we having a good monitoring protocol is key. It's really, really essential. So our colleagues who are in cardio oncology have thankfully made guidelines for us talking about using ACE inhibitors early in the course, because they're very helpful in managing drug-induced hypertension from these agents. But we try a lot of times to avoid certain calcium channel blockers. And we'll even, again, and this is something that I consult with pharmacy about, Grace or her colleagues, about considering even taking people off of certain calcium channel blockers because there's such pervasive interactions. And so, and again, if they have a cardiologist prescribing this, I'm not just going to yank them off, I'll collaborate, but it's something that we have to really think through. I would also just say that, you know, when folks are on chemotherapy, especially if any of it could have renal toxicity, and especially in folks who only have one kidney, we try not to use a lot of diuretics if we can, and just really start with those ACE inhibitors or those dihydropyridine calcium channel blockers. Sometimes they benefit from a beta blocker that has a little bit of alpha activity, and a classic example of that would be carvedilol. But again, there can be drug interactions. But this is a biggie as well. QTc prolongation is something that we monitor for. This is vandetanib is particularly known as having this risk, and we care about QTc prolongation because if the QT interval gets really long, then it can result in patients having a potentially fatal arrhythmia. So we always make sure we keep people's electrolytes in balance. That's essential. And then again, different agents have different EKG monitoring guidelines. So for each of these, I really do personally delve back into that and then get to work with my oncology pharmacy colleagues, since we have that resource here, in trying to create a good monitoring protocol. Now, perforations and fistulas are a very scary and thankfully rare potentially adverse effect. But while we don't, again, this is unlikely to happen, but is scary. And we do talk to patients about this, mostly in that we don't want patients to just sit on symptoms that are distressing to them. Most of the time, if someone is sick enough to have a perforation or a fistula, they will present to medical care. But, you know, we do have many stoic patients who would sit on some sort of unusual change to their color or smell of their urine, for example, and just sort of live with it. And for a while, thinking that maybe it's a side effect of the medicine. So this is part of the way we talk about this, is not to say, you know, give them specific instructions if they think they have a fistula, but rather just to say, not only is it okay for you to call us, we actually need you to. It's essential that you call us if things are changing in a way that doesn't reverse very quickly. Bleeding is another risk, and this is tricky. You know, cabozantinib is called out directly here, but this is something to watch out for, especially because we know that a lot of patients who have active cancer can get blood clots and are going to be on anticoagulation. So this is something to look out for. But thankfully, it's far from a guarantee. Voice changes are common, and while I think usually this is not a clinically significant symptom, it can be a very personally significant symptom to patients. So I would recommend to give your patients a heads up about this and let them know that this is common, so that they won't feel scared or they won't think that they're sick, just because a little bit of knowledge goes a long way when they're starting a new treatment and we're asking them to be vigilant. Just preparing them so that they feel safe is essential. And then proteinuria. This is another one that we usually need to monitor for. I think it's probably rare that a patient would come in saying, you know, I have this foamy urine all of a sudden that's due to proteinuria, but it really falls upon us to do some monitoring for that with urinalyses. And even if they have a high degree of proteinuria, sometimes we even need to do a 24-hour urine protein. So this is, and you know, ACE inhibitors and angiotensin receptor blockers can help with that, given their role. But a lot of the time, this is going to take an interdisciplinary management approach if patients have significant proteinuria.
Libby, can I ask you a quick question? Just curious. In a previous echo, you had mentioned that you had a great slide that showed kind of when these occur for patients. And I'm thinking,
Sure.
Of course, survivorship is the hat that I often have on. But I'm wondering, for many of these patients, like, for example, voice changes, you're right, that could be a very personal dilemma for someone. Maybe if they sing or, you know, whatever, does that tend to go away in time, or does it, I mean, have you seen it progress? Is it something they have to learn to live with? Is this something that, you know, lessens after they've completed therapy?
Well, so, and these, TKIs are used differently with different cancers. For kidney cancer, a lot of times patients are sort of continuing these as long as they're helpful, and as long as they're tolerable, because they're often for metastatic disease. But what that can mean is that patients have, for example, a lot of trouble with hoarseness, that it often will persist throughout the length of time that they're on the treatment. However, if we do withdraw that treatment and then change them to something with a different mechanism of action, or give them a treatment break, I have seen it improve. And, not to put you on the spot, Grace, I don't know if there's any particular guidance you give about that, but my experience just in clinic has been that typically hoarseness does persist throughout the length of time that people are on treatment. Some of these can be progressive. For example, hand, foot, skin reaction can be progressive with time if we're not managing it quickly, or managing it really efficiently. And sometimes even if we are, but the voice changes I tend to see kind of occurs and then plateaus quickly. It doesn't, in my experience, doesn't typically become progressively quieter and quieter with time. And so I don't know if there's any other guidance about that, but that's my experience.
No, I would agree. It usually stabilizes. And then once they come off, it usually goes back to normal after a period of time. It's normally not something that would persist forever if they change treatments, but it is just bothersome to the patient. I tell them there's nothing that we can, unfortunately, there's nothing we can do to improve that side effect, but it's just more bothersome to them.
Yeah. Yep. Well, in part of my own personal mission is all about preparing patients and their support persons to try and sometimes do preventive work to try and make sure that we spare them from as many adverse effects as possible, and also have a really good management strategy in place that they can enact on their own. I find all the time, I don't know about some of you, but I honestly find all the time that patients ask me, what can I be doing? And I think that's a really common question. So some of what we're talking to them about is, we can give them a task list. And I think it's empowering for patients, empowering for caregivers, and gives them a framework, kind of a mental framework to work through it. So what while this hasn't been studied, I kind of have I have a particular strategy that I wanted to share in case it would be helpful with other folks. And if folks have other strategies, then please definitely put it in the chat box, because we can always learn from each other. So let's see, then I think the next slide has a little bit more detail. Let's see. Okay, so for an example of this is that, and we do give, I know this is really wordy, and you will certainly have access to this later to refresh yourself, because I'll cover it relatively quickly to make sure I'm respecting all of your time. So when we are starting these medicines, I give patients verbal instruction about this, and then written instruction that I physically hand them, and also send them through the patient portal, both, so that they can be taking action from the beginning to try and prevent and then mitigate this. So with hand-foot syndrome, we talk to them, if patients have significant calluses, before they're even starting it, while we're working on getting it approved by insurance, we're working on getting it shipped to their house from the specialty pharmacy, I'm saying, okay, well, if they have significant calluses, let's get you in with the podiatrist to manage those beforehand. Then what we often talk about is trying to avoid exposure, and starting from the beginning, before they even start the medicine, avoiding exposure of hands and feet to a lot of friction, to a lot of heat. And these are behavioral changes that they need to take, but we tell them to start it from the beginning. And even sometimes we find that if their support persons also do these same things, then it can help reinforce it for the patient. But we give them specific examples of things like, if you're going to have, if you have a job that you're going to be doing that has a lot of friction, then try to wear gloves to prevent a lot of friction directly on your hands. If you're going to be washing dishes, either use lukewarm water or wear gloves. If you're using a heating pad on your stomach, don't put your hands on it and rest them on there. Those sorts of things. We also have them start using a good moisturizer twice a day, every single day, to their hands and feet. Because kidney cancer disproportionately affects men, sometimes this is the first time that my patient has ever encountered the idea of moisturizing their skin twice a day, every single day. So, but this is something we start from the beginning. We also have them go purchase a hand cream that has 10% urea in it, such as, this is one brand, but I'm not advocating for it specifically. This is just one example. And be prepared that if they get any little callus lesions, that then we have them start applying that twice a day to help maintain that. And then we also tell them that we need them. We won't tolerate it, that we are asking them to please tell us if they have any tender places or any red places on their hands or feet that are bothering them, so that we can prescribe them a prescription cream. Really try to emphasize the importance of communication about that. I don't personally prescribe the steroid cream from the beginning because I don't want them to start using it unless it's clinically needed. But we also just emphasize to them that them telling us about the side effects is not going to mean that we're going to yank their treatment away or we're going to make them go without treatment, but rather it will just allow us to manage it so that they can stay on treatment. Another example of what we ask them to do is, if they can, so if they either have a healthcare flexible spending account, if they have, or if they have the money to be able to do this, that we think it is best if they can obtain an automated blood pressure cuff, or go to a pharmacy that has a blood pressure cuff there, to start measuring their blood pressure 3 times a week. Again, we're instituting this before they ever take the medicine. And the goal is to do this for 3 times a week, but for 2 to 4 weeks after every single change in dose. So if we're starting and we're needing to go down, then we still need this information. We ask them to physically write this down and to notify us, ideally through the portal or through a phone call that lists the values, in order for us to know if we need to be changing their blood pressure medicine, starting a blood pressure medicine, or if we're tapering down their dose due to side effects, do we need to decrease their blood pressure medicine dose? So in terms of diarrhea, we don't ask them to do any prospective changes in their diet or anything like that, but we do tell them to go buy a bottle of over-the-counter loperamide, 2 milligram pills, to keep at home, and tell them that if loose stools occur while they're on treatment, we will plan to use this medicine. We give them a general guide that we would typically have them take 2 of those pills after the first loose stool that they have, and then 1 after each subsequent one, but that we actually ask them to notify us before doing that so that we can give them other guidance. And then I do want to talk a little bit specifically about the hand-foot syndrome, and I saw that there were some questions in the chat box about this. So this is different, especially because there is this other phenomenon called palmar plantar erythrodysesthesia, which is one of my favorite medical terms. But these are different phenomena. So there are some cytotoxic chemotherapies that can cause a hand-foot syndrome as well. But the difference is, and what we tell patients specifically, is that these skin changes can occur quickly after you start the medicine. They often start out as calloused areas or thickened areas of the skin that can become red and either tender or painful. It usually does not consist of any sort of neurological-like sensation, like pins and needles or something like that. It's not something that could be confused with carpal tunnel syndrome or something like that. They usually are, because these are sores. They usually are they can be tender, or sometimes even if they're not touching them, they hurt. But the other things I'll mention is that they happen often at places where there's more friction or at pressure points. And so even for folks who, let's say, if they have had an amputation or something like that, there are reports that people at the end of their amputated limb, where their skin can have friction against the prosthesis, that's not a palm or a sole per se, but they can get this skin reaction there. Also, there is reports of during the era, during the early aughts, remember when everybody had a BlackBerry phone with a wheel on it? There were these reports of people who got these lesions on the specific part of their thumb that touched the wheel, and it's because they're just doing it frequently. So we just try and emphasize these things so that they can be on the lookout for it. So that's what I wanted to share there. And then these are some examples. I will tell you, I don't share photographs of patients. I think when they're starting a new medication, I think this would be potentially scary to patients, and so I don't routinely do that. I suppose if I had a patient who really felt like they were a visual learner and really needed it, then I would dig up some pictures. But just for everyone's reference, it can be these kind of callous looking areas, as you can see in the grade 1 picture. Just there are these areas that sort of where the skin looks whiter, and that's where it's getting kind of callous. Then we can see in grade 2 where patients would, in grade 2 patients are having pain, and you can see these kind of blister-like lesions. And in grade 3 and beyond, they really can be these severe and very painful blisters. So that's why we talk to them about just good prevention. So yeah, I think I did put some animations there, and I talked through them a little bit, but these are some examples. So that's why we're trying to, if anything, try and keep it to grade 1 if possible, rather than getting to grade 2 or 3, but really trying to avoid. This is just a different visual depiction of some of the things that we often do and what we tell patients to do. And since all of you who are participating will have access to this, then you can refer back. But as I said, we're trying to use a lot of prevention, managing any thick calluses from the beginning, using moisturizers regularly. And I tell patients every single day, twice a day, the palms of your hands and the soles of your feet. And then again, we give them those mitigation strategies in case they have some calluses that are developing or tender areas. So to get back to a poll, I wasn't sure if any clinicians who are joining us are able to comment, if any of you have used some agents or observed these being used. Is there any consensus? Is there one most difficult symptom to manage, either the hand-foot skin reaction, proteinuria, high blood pressure, or beyond? Because, there is kind of things do run the gamut a little bit. Yeah, and I see folks who are mentioning hypertension, and I certainly relate to that. And my perspective, my experience has been that by having them get in the habit of keeping a log and reporting the log to us weekly, it at least gives us a sense of what's going on. But this is a time in which there's no shame in reaching out to one's nephrology or cardiology colleagues if any of us need more help in managing that. But we often will kind of follow a stepwise approach of using an ACE inhibitor or angiotensin receptor blocker first, using those dihydropyridine calcium channel blockers like amlodipine, sometimes using a beta blocker. But I personally just follow the JNCA guidelines, and I'm sorry, I don't remember what those are called, but they're like the American Heart Association guidelines for managing hypertension is where I go every single time. Because that's what we tend to see, just trying to deprioritize diuretics whenever possible for the sake of their beans, their kidneys. Okay, back to the case study, and then we're going to pass it back to Grace to talk some more about some additional monitoring and management strategies here. So mixed W really finally receives their, I used the wrong pronoun there, I apologize, their supply of cabozantinib after they receive it, and the pharmacy often will need to be specified by their insurance. So when starting a TKI or really any oral cancer therapy, what are the best practices for promoting safety, quality of life, and adherence? And what are the other pieces of the puzzle? Because in some ways it can be a little bit spooky because patients are being asked to manage their cancer themselves in a way that is relatively new to the world of oncology. So if any of you all have any particular strategies that you have observed being successful in promoting adherence or communication about symptoms and quality of life, please put it in the chat box so that we can all learn from each other. But in the interest of time, I think we could probably just, and Katie, you can call those out in between slides if we see some of those come in. So the next few slides, I'm going to pass back to Grace to talk to us some about the oral chemotherapy practices that we use here at the University of Kansas and what generally that looks like from a workflow and process standpoint, and as well as giving us some information about where the patient interactions come in.
Right, thank you. Yeah, like Dr. Wolf Birchfield mentioned, it can be really scary sending a patient with a prescription where they are responsible for their cancer therapy. So one of the things that we like to do here at KU is really treat it just like we would if we were managing someone's IV chemotherapy. And that means we have that discussion with the patient and obtain a consent before the prescription is ever sent. And that's to make sure that they don't get a call from a pharmacy about a drug being ready that they haven't heard about yet. So we don't have any test prescriptions at KU. Every prescription that is sent for oral chemotherapy or an oral anti-cancer therapy is considered a true prescription. So it starts with that discussion with the patient and the provider about the treatment. The patient is consented, and then that prescription is signed and released. And we actually do use Beacon, which is part of our EPIC module for cancer therapies, for our oral chemotherapy agents in addition to our IV therapies. So we treat it with the same kind of respect, even within our electronic health record. After it is released, it doesn't automatically go to the pharmacy. It actually goes to a separate pharmacist queue, and a pharmacist completes an independent initial assessment of that therapy, looking at the patient's height, weight, their dose, making sure their renal function and liver function are okay. We evaluate for drug-drug interactions. We go through all kinds of parameters to make sure that this really is the most appropriate treatment for that patient. And then we also enroll the patient in an oral therapy monitoring program. Once we go through our initial assessment, then we verify that prescription from our queue and it goes on to the pharmacy. So I did want to ask all of you, are there other factors that can influence your choice of treatment? I know that when we're having this discussion with a patient talking about what treatment to choose, the cost of these agents can be prohibitive. So even if we're able to identify the ideal treatment regimen for a patient, that cost of treatment can create barriers. So have you encountered circumstances where patients have been unable to take recommended treatments due to the cost of medications? And that would be for any cancer, not just for kidney cancer. And if you have, you can say, yes, you've encountered barriers, or no, if you haven't encountered barriers in the chat. And if you have any strategies to overcome those barriers, please let us know. One tricky thing that I think that we've encountered once we send these prescriptions is follow-up and making sure that a patient actually receives it, because sometimes they encounter these cost barriers and we don't know about it. So we'll actually set reminders for ourselves in our pharmacist monitoring program to follow up with those patients and make sure that they have either received the prescription or that we're working toward obtaining it for them, whether doing prior authorizations or trying to get letters from the physician to support the treatment. We have a few of those strategies. Okay, yeah, a lot of barriers to affordable medications. Right, I think we can go to the next slide.
You're there.
Oh, thank you.
It looks oddly similar to the previous slide.
Here it is. Thank you. So the next thing we do is we complete oral chemotherapy monitoring. So once the patient is enrolled in the program, we like to complete education with the pharmacist before they even obtain their medication. That way, as soon as they get it, they know all about it, from handling, administration. We even talk about reproductive risk and drug-drug interactions. Disposal, all of those things we think are really important for patients to know about, since they are the ones handling this therapy themselves. It's not like a nurse going and hanging an IV bag. They're actually handling these medications themselves, which could be toxic if a small child came in contact with it or they're animal ate it or anything like that. So we really do try to teach them how to properly handle these medications. And then we also do toxicity checks. So after they've started taking it, we like to call about 2 weeks after, or we try to see them in clinic to see how they're doing. Are they missing any doses? And if so, why? So we're looking at adherence. We also want to make sure they're taking it correctly. So asking them how they're taking their medication to make sure it's the right number of tablets at the right time of day, whether it's with or without food, all of those pieces of information. And then we set up a follow-up with that patient. And depending on the risk category of the drug, we do that every 3 months to every year. So for a drug like cabozantinib, we consider that to be a high-risk drug where we would want to follow up every 3 months due to the side effects from that medication. That's different from a medication like abiraterone, where patients usually tolerate it quite well. We'll do that 2-week toxicity check, and then we follow up every year after that. So this is just looking at our EPIC. So we actually will release this from Beacon, just like an IV therapy. So the consent is obtained. That's part of this Beacon record. And then it is signed and released by the provider. And you can see that it's actually queued for pharmacist review. So then it comes to our pharmacist queue. And within our pharmacist queue, we enroll the patient in the oncology monitoring program. We review the prescription, make sure that everything about this prescription is correct for the number of days, tablets, dose, and all of that. We do our initial assessment note, enroll them in our monitoring program, and verify the prescription to send it to the correct pharmacy.
Hey, Grace, just for a brief moment, because I know you have a few other slides, but I wasn't sure if you might be able to share what has changed in any of this related to doing more telemedicine in terms of consenting and kind of what that looks like and what we consider to be our best practices.
Absolutely. So we have done a lot of this through telephone calls and telemedicine, but with consenting, we still require that a consent be completed and that a note is entered, even if it's done over the telephone or a telehealth appointment. So that has to be documented by the provider, and the pharmacist is looking for that information when they are releasing this prescription to make sure that has been completed and that that conversation happened with the patient. We have been doing a lot of telehealth for these patients for a long time. What's nice about the expanded telehealth is that now it's more common practice for us to have these appointments with patients. So it's really nice to be able to put a pharmacist appointment on a patient's calendar so that they know that we're following up with them and why they have this toxicity check. So that's been kind of one of the nice things that has happened through telehealth expansion.
Thank you so much. I think that's a great summary. And I do think that, again, my Grace and her colleagues have done a lot of this telemonitoring and telehealth. But I think that this becoming more frequent and more accepted among our patients, or just more possible among our patients, is helpful. Unfortunately, telemedicine in the United States is still a big cause of disparity, just because folks have to be able to have Wi-Fi or devices that are not free. And so it's not always possible. But Grace, you do when you were talking about telehealth, a lot of what you're doing is just by phone, correct?
Mm-hmm.
And so it's not, you're able to overcome a lot of those disparities, since most patients are able to have some sort of phone.
Absolutely. So if they don't have an appointment with clinic in the time frame when we need to reach them, we usually call them on the phone and check in to see how they're doing. If they have an appointment with a provider, we always try to do that face-to-face whenever possible, just because we have usually the best interactions there. But we want to make sure that even if the patient doesn't have an appointment, that we're still following up. And so we call them regularly because there's a lot of things that can happen between those visits, where they might have a side effect that they're not reporting, or they might be taking their medication incorrectly. And so catching those things early has been really helpful. We also send all of our initial prescriptions to our KU specialty pharmacy. And that's just because we have a whole team of pharmacy patient advocates who work with patients to help them afford their medications. So their goal is to help every patient have a copay that is affordable, with a goal of a $0 copay. Of course, that's not always possible, but that's what they're striving toward. So they work with copay cards, grants, foundations, drug assistance through drug companies, and try to help patients afford their medications. And they also coordinate with the oncology pharmacists in clinic if they run into any issues with that prescription. So that's why we send it to our pharmacy first. Oh, I think you're muted.
We're all living in an increasingly digital world, but as Grace described, even just using the telephone, which has been around for a minute now, can help us to kind of monitor patients. So I wasn't sure if this is something that any other practices happen to do or have the bandwidth to do or have personnel to do. So we can do another quick poll and just see, and also you're welcome to share in chat box if this is something that happens in the practice where you work or something that you've observed. Also, if this is done, we'd love to hear more and learn from each other about who in the practice does that, because not all practices are able to have a dedicated oncology pharmacist who are there conducting this. So if there's any particular roles that do this, then we'd love to hear more about this. While we're waiting for this, and again, not trying to put Grace on the spot, but I know that our KU pharmacy interacts a great deal with the specialty pharmacies that are sometimes either required per the drug manufacturer or per insurance agencies. So we know that this is common, that a lot of insurances specify specialty pharmacies where these drugs must come from. So are there any of these steps that you have observed are done through these other specialty pharmacies, be it a Credo or what have you? I wasn't sure if any of this particular monitoring is done. And then I do know that occasionally you get interactions with people at those pharmacies, maybe if patients aren't filling the drug on the expected frequency. So I'd love to hear more about that.
Of course, yeah. So we do sometimes have to send them to the patient's preferred pharmacy by their insurance. And so in those situations, that pharmacist will probably reach out to the patient as well. Diplomat, I think, has been pretty proactive at calling those patients. I've seen quite a few emails come from them with different things that patients have reported, whether it's a side effect or a question about their medication. So every specialty pharmacy is required to have a pharmacist available 24 hours a day, 7 days a week. So those patients will often call those pharmacies with questions as well. So we do have some interaction with those pharmacies, especially if they're running into issues with filling those prescriptions. But they usually may do some kind of toxicity check, but since they don't have the full medical record, they're working with more limited information.
Sure, they can't really do a risk-adapted strategy. If we know that someone has peripheral vascular disease and hypertension, they may not know that. I wasn't sure, I think I didn't realize that all specialty pharmacists had to have a pharmacist themselves available 24 hours a day. And do you happen to know, which you may not, but if patients can ask to speak to those pharmacists, or if it's something that, how they would interact with that pharmacist, if at all?
Yeah, they can absolutely ask to speak to a pharmacist and ask questions of them. Yeah, they're welcome to do that. Okay.
That's a good resource, I think, because every practice is structured differently. And I think it's important to know what resources are more, I suppose nothing's universal, but what resources may be available more consistently throughout the US and in all sorts of different parts of the country. I think that's really encouraging, actually. I mean, I certainly wish we could clone you and all of our colleagues here, but short of that, that's a good starting place, at least as a reference point. I did want to share a little bit more information just about patient resources that I happen to like, and I share with patients and their caregivers quite a bit. So now this is specific to kidney cancer in that this is a patient advocacy organization for kidney cancer. However, it does have some resources that are not just specific to kidney cancer and kidney cancer treatment. So if I don't happen to treat this, but if I were treating, let's say, hepatocellular carcinoma and I was going to be using cabozantinib, depending on how I thought an individual patient might feel about this, I think it'd be very reasonable to share this resource with them, because I really like this Just Diagnose toolkit, because it shares some information about what the side effects of treatment are. And it talks about diarrhea. They have a whole lot of, and they even distinguish a little bit here between if someone being on immunotherapy versus being on a targeted therapy. And so I think these are some really great resources, and I've gotten good feedback from patients and support people about that. And then another one that I will not take credit for, I learned about through Grace and her wonderful colleagues, is this great resource called Oral Chemo Edge Sheets. Many of us probably refer to a few other websites to give our patients and their support people kind of this patient-facing information. However, I personally have really begun to love these oral chemo edge sheets, which are available for free. And I just think they're a little bit more thorough. I think they're organized in a way that's very easy to read. I think they address questions about, sort of things like don't cut your capsules, don't cut your pills, et cetera, and give some good guidelines that generally align with what we think are best practices. So I'm a really big fan of those and hand those out like candy. So I think that we're getting close to the top of the hour, but we can definitely answer any questions that folks may have, or try and have a little discourse about any particularly difficult clinical situations that people are encountering. So anyone can put it in the chat box or pipe up. I did have one more question that I thought we could try and drill down to a little bit more. And Grace says, you are not yourself a pharmacy patient advocate, I know, but I wasn't sure if you have any general guidelines about the way that we can go about getting patients assistance in our last 2 minutes, and what resources might be more universally available in terms of giving patients, copay relief.
Absolutely. I mean, the first step that I would take is to go to that medication's drug company website and see what patient resources they have available. So if I'm prescribing cabozantinib and don't have a pharmacy patient advocate available, I would just go to that website for Cabometyx, and they usually have a separate section that's patient resources with a phone number available. So there are a lot of drug company programs available with copay cards and enrolling them in initial free drug trial periods. And so I usually just go to the company first for anything like that.
Okay, that's great. Yeah, and because these products are manufactured by different companies, what the sort of rules or, for example, the kind of financial qualifications differ somewhat between them. For example, when it comes to prostate cancer therapy, I've had folks who were able to get a drug that get copay assistance for something through one pharmaceutical company, but not for another. So that's a good question. And I see that our colleague, Dr. Potts, put a question in the chat box about diffusing how the idea of kind of doing I like their unboxing conversation, or their unboxing video, like all the YouTubers out there. They do that all the time with their medicine to kind of, I think that's a really natural touch point. So I love that idea. Well, I will leave it to Katie to close out, but thank you all for your participation, and we'd love to see you all join us for our final session, which is going to look at oral chemotherapy agents and immunotherapy together.
Yes, and we're going to have Jennifer Hines, someone near and dear to your heart, that will be joining us. We're super excited about that. And just one more quick announcement. Mary Ellen Potts, Dr. Potts is on our call today, and she has been chiming in with her own questions. She has doing a little sub-study within this study, and is looking for individuals, clinicians, to participate in a quick little interview with her regarding ICI therapy and toxicity. So reach out to her or myself, and I can get you connected if you're interested in participating. Finally,
yes,
don't
please,
forget, we've got 12 puns is your code for CEs today, and that deadline is July 22nd. Again, at the Masonic Cancer Alliance, this is where our enduring materials for this series is living right now. And again, we look forward to seeing you next time at that will be our final Toqq-Rcc series Echo on August the 13th. We can't wait to see you guys there. And thank you so much, Grace, for your time and efforts today. This was a really great talk. We appreciate all of you. Have a great rest of the day and a good weekend.
Bye. Thank you.
Bye-bye.
Thank you.